Although already covered in a longer 3 in 3 series video, acute kidney injury is extremely high yield for USMLE. Let's talk about acute tubular necrosis following hypovolemic shock. When this happens, the serum BUN to creatinine ratio is around 10 to 15, as typically seen in acute tubular necrosis. This is in contrast to pre-renal azotemia when the ratio is over 20. You also want to look for other things that kind of support your diagnosis when it comes to acute tubular necrosis. Number 1, the urine osmolality is around 300 to 350 milliosmoles, but it's never less than 300. Secondly, the urine sodium is over 20 milliequivalents per liter. And lastly, the fractionated excretion of sodium is more than 2%. You can have acute tubular necrosis definitely from having prolonged hypotension. The hallmark finding and the most high yield thing is that on urine analysis you have muddy brown granular casts that consist of renal tubular epithelial cells. It can be a pretty nonspecific finding, but it's very sensitive for finding acute tubular necrosis. Some other hallmark findings of renal failure are red blood cell casts. This is glomerular nephritis. White blood cell casts are interstitial nephritis and pyelonephritis. Fatty casts are seen in nephrotic syndrome, and broad and waxy casts are seen in chronic renal failure. It's important to remember these because these can definitely save you on test day.